Okay, recording, and I'm going to share the screen again. Okay. All right. Well, look, welcome everyone to Paediatric Teaching today. There's a lot of people online today, which is really good to see. For the first time, I see Dr. Leilani Sawari and the Alatal team online. So welcome the people from Alatal. That's great. I think, yeah, that's good. Well, today I wanted to talk about common kidney diseases in children, and we often don't think much about kidney diseases because they're often a bit more silent. And but I wanted to talk to you today about 3 common kidney diseases in children that you need to know about for we all need to know about as pediatricians. And first of all, I wanted to just talk about a case that I looked after recently that I thought taught me something important about kidney disease. Now, it's not, I'll explain what it taught me about kidney disease, but I'll just describe the case a little bit. And this was a 14-year-old girl who I looked after last month, and she was previously fairly well, although she was a diabetic, but she'd been well controlled, and she presented with severe headaches and vomiting, and was quite lethargic and was poorly conscious when she came to the hospital. And she had a lumbar puncture, and that showed that she had staphylococcal meningitis. So so far, we're all familiar with children who present with signs of staphylococcal meningitis, perhaps, or some sort of bacterial meningitis. She had Staph aureus on her blood cultures, and it turned out to be MRSA. So again, that's something a little bit unusual, but children who have diabetes are a bit more prone to MRSA infections from the community. So that so far, it wasn't that surprising. And she was started initially on ceftriaxone, as you would for any child with meningitis. And then we found out when it was MRSA, we put her onto vancomycin. And she had the usual other sorts of treatment, just fairly routine oxygen and supportive care and close monitoring. And we thought everything was going okay. But then within about 24 hours of her being admitted to hospital, she became oliguric. She had only passed 60 mils in a 24-hour period. And you might say, well, how do I know that's oliguric? Well, we need to have a definition of what oliguria is, right? And so oliguria is in any person, child or adult, passing less than 0.5 mils per kilo per hour. Now, obviously, we don't pass urine every hour. We might pass urine every 3 or 4 hours, and it's the accumulated equivalent of that, right? And so, for example, a 50-kilo child, like this girl was, she was 14 years old, and she had meningitis, and she should be expected to pass, because she's 50 kilos, about 25 mils of urine per hour. Or if you multiply that by 24, then 600 mils a day. All right, so you'd be surprised if she passed less than that. And most people, of course, pass much more than that. They pass more than 1 mil per kilo per hour, right? But this is 0.5. So she was certainly oliguric because she'd only passed 60 mils, not 600 mils, but 60 mils in a 24-hour period. And so that seemed to be a very big problem. And I just want to show you a graph of her creatinine level that occurred during her first few weeks of admission to hospital. And often we're not easily able to measure creatinine or urea very regularly, but on this occasion, we're able to measure the creatinine and urea. And I'm sure all of you know normal creatinine level is somewhere between 30 and 80. Now that's micromoles per litre. Depending on the laboratory, they might use different metrics, they might use different units, but 30 to 80 micromoles per litre. So when she came in, she was around about, I'll just admit someone. When she came in, she was around about normal. So in the upper range of normal, about 70 or 80. But you can see that her creatinine rose very quickly. These spaces are 4 days, about 4 days. So 3 or 4 days between each of these spaces. And each of these, so you can see that her creatinine rose dramatically in the first few days after her admission, and it reached, her creatinine went almost as high as 900. So I think 880 was the highest her creatinine went. and then her creatinine slowly came down. Right, her urea rose as well, but it was a little bit slower. But because the normal urea is somewhere between 2 and 6.5, again, micromoles per litre, her urea got up to about 40 or 50, so many times normal, but it's not as dramatic as the creatinine level. But the question I had was, well, why did a patient like this who has staphylococcal meningitis, why would she develop such severe renal failure? And can anyone suggest why that might be? Why might a child who presented as I've described develop such severe renal failure? Can anyone suggest any cause?
Sepsis?
Yes, okay, good, Annette. Yes, certainly sepsis can do it, especially if you're hypotensive. If your blood pressure is low, then you can get renal failure. That's true. But sometimes we blame everything on sepsis. And the lesson I wanted to convey here is the lesson that when children develop renal failure, it's often not just one thing. It's often not just because she had staphylococcal or she had staph meningitis. She wasn't very hypotensive, but she probably had some dehydration, right? But it's often not just one thing. Can anyone else suggest a reason why she might have developed such severe renal failure? Okay. Yes.
If the child is not being given enough fluids and is not taking enough, then child would most likely have hypovolemia and renal failure.
Yes, that's right. I think that's an important component. So first of all, sepsis. Secondly, hypovolemia. But this is what happened. I think that there were many causes, and the message I thought was that often when a child develops renal failure, with kidney failure from being previously well, there's often not just one cause. Sometimes there's one cause, but sometimes there's a number of causes. All right. And firstly, that this child presented, if you remember, with headaches and vomiting, and she was quite dehydrated when she presented. So she'll have dehydration and pre-renal hypoperfusion of her kidneys, as well as the staph sepsis. But whenever a patient develops renal failure, you should think, well, what other factors are involved? And in this case, this child was on vancomycin for her MRSA infection, and vancomycin could be nephrotoxic. And when we measured her vancomycin levels, they were very high. And so I think that was a big cause of her kidney failure. She also had some paracetamol and some ibuprofen for headaches. What do you know about that? Sometimes we would use ibuprofen's a bit like indomethacin. It's a non-steroidal anti-inflammatory drug. Well, what do you think about that? These drugs, ibuprofen or indomethacin, can sometimes cause kidney failure in people who are susceptible. So if you have sepsis and hypo and dehydration, and someone gives you ibuprofen or indomethacin, a non-steroidal anti-inflammatory, then that can reduce kidney perfusion. It particularly occurs in elderly people, but it can also occur in children, as it did in this child. I mean, and the fourth, I think, big reason why this child got kidney failure is because she had a CT scan of her head. And whenever we do a CT scan and we're looking for like contrast enhancing abscess or something like that, we want to see if there's any contrast enhancement, we give intravenous contrast. And intravenous contrast is nephrotoxic. It's like vancomycin or ibuprofen. And the problem for this girl was that in the first 24 hours after she came to hospital, she was dehydrated, she had staph sepsis, she got vancomycin, she had ibuprofen for headache, and she got intravenous contrast for her head CT. And it's the combination, I think, of all of those things that led her to have renal failure. Perhaps less contributory, we looked to see if she had some underlying diabetic kidney disease, which could have been the case, but she's quite young to have diabetic kidney disease. So I think it's the other things: dehydration, sepsis, vancomycin, ibuprofen, intravenous contrast. And we've always got to think, if we see a child who's got kidney failure, we've got to think to ourselves, well, what drugs is the patient on that might be causing a worsening of renal function? Because it's a big deal. If a patient like this gets kidney failure, it's a very big problem, and it can set recovery back a very long way. And so we've got to think about the kidneys when we're looking after these patients. So the management for this girl, you might think, well, this child might have needed dialysis. She didn't need dialysis. She only needed good supportive care. And despite her creatinine going up to 800 or 900, she just needed supportive care. So we had to correct her dehydration. And then only after that, for the next few weeks, while her creatinine was very high and while she wasn't passing much urine, then only give her enough fluid to replace her insensible losses. I'll explain what that is in a moment. We had to closely monitor her acid, base, and potassium. And when you're looking after a patient with kidney failure, you need to decide on the indications for doing something else, right? The indications that you would do dialysis, for example. And in this child, you have to have thresholds that mean you avoid dangerous complications of kidney failure. And really, the dangerous complications of kidney failure are severe hyperkalemia, so the potassium going very high, because that can cause cardiac arrhythmias. So that's a very dangerous complication. That's the most dangerous complication. The second one is severe acidosis. So if the pH goes very low, like less than 7, then that can be dangerous to the patient. You need to avoid severe edema, and you need to avoid uremia. So if the urea level goes very high, like 50 or 60, then the patient will often become unconscious. And of course, that becomes a problem. So we set at the start, these were the indications. If something happened, then we would put in a peritoneal dialysis catheter and start to do peritoneal dialysis on this child. I say careful use of frusemide, because if you give frusemide too early in patients who've got kidney failure, then often their kidneys aren't capable of responding to the frusemide, and all it does is build up in the renal tubules, and actually that can cause worsening kidney failure. So frusemide, like vancomycin, like ibuprofen, is nephrotoxic if you give it in big enough doses. It's toxic to the kidneys. And so it's important that we certainly did use some frusemide on this child, but only we waited until we thought that that she was properly hydrated, that there was no major complications, and then was careful about the use of frusemide. So you just need to avoid all nephrotoxic agents. I talked about insensible losses and how do you work out that in a patient with kidney failure? Well, insensible losses are really just the water losses that you lose from your skin and from your respiratory tract when you're breathing. And in a normal adult, it's a maximum of 800 mils a day. So she was a 50 kilo 14-year-old, and so close to being a normal adult. So we only allowed her to drink 80 mils of fluid a day, whatever it was, whether it was milk or juice or water. She couldn't have any more than 800 mils per day. And if you've got a child, it's around about 30 mils per kilo per day. That's about your normal insensible losses, up to 800 mils. So if you've got a 30 kilo child, then it's still only 800 mils. If you've got a 10 kilo child, it's around about 300 mils, right? And so if you're just replacing insensible losses in a patient with kidney failure, typically don't go over 800 mils a day, unless of course they're dehydrated and you want to clear that up. Right. So I wanted to present that case because I thought it illustrates some important points about nephrotoxic drugs, drugs that are toxic to the kidneys, and how sometimes in a susceptible patient, there can be more than one cause of kidney failure, right? And I think we look after a lot of children that have this type of pathology They might have an infection, they come in dehydrated, they get medications, and their kidney function deteriorates. Right. Look, today I wanted to talk about some common kidney diseases, and the first one is nephrotic syndrome. And I think, as I say, we don't often talk about kidney disease, but I want you to become sort of fairly, have a good knowledge of nephrotic syndrome and glomerulonephritis, right? They're the two that you really need to have a good knowledge of. I'm going to speak briefly about some chronic kidney diseases, some congenital kidney diseases, but mostly I want you to learn about nephrotic syndrome and glomerulonephritis. And so I think you all know that nephrotic syndrome is defined by severe proteinuria, hypoalbuminemia, and edema. They're the cardinal features of nephrotic syndrome. There are some others that children with nephrotic syndrome also have, but children with nephrotic syndrome come in with generalized edema and hypoalbuminemia and proteinuria. The most common type of nephrotic syndrome in children is what we call idiopathic. It's called minimal change glomerulonephritis, minimal change nephrotic syndrome, and that's about 90%. And then 10% are some other conditions, and I'll show you some pictures of some of these other conditions. The problem with nephrotic syndrome, a bit like chronic kidney disease, is you have to look after these patients' kidneys until they get better. They almost always get better, not always, but almost always. So 80 to 90% of children with nephrotic syndrome respond pretty well to steroids, and from that, about 80% will have one or more relapses. So they respond well, and then sometimes they relapse. And in the meantime, while the child's getting better, you need to prevent them having hypovolemia, hypertension, infection, and thrombosis. And they're the main acute complications. Children with nephrotic syndrome usually don't have kidney failure. They just have they have marked leakage of protein from their kidneys, but they don't have kidney failure like I showed you in the previous child with a creatinine and urea that rises markedly. When we're looking at children with edema, we might think, well, any child with edema could have nephrotic syndrome, but I think it's important that we have a differential diagnosis of children with edema, and we need to think about how we'd make an assessment of the different causes of edema. All right, and so many children with hypoalbuminemia don't have nephrotic syndrome. They have some other cause. All right, it might be their albumin is very low because they've got protein energy malnutrition. They've got kwashiorkor. It might be that they've got increased losses. I'll just admit someone else. They've got increased losses either from their kidney, from nephrotic syndrome, or some children have losses of protein from their gastrointestinal tract because they've got a protein losing enteropathy or worm infestation. That can cause you to lose protein. And so often children that have a combination of severe malnutrition and worm infestation will have hypoproteinemia, hypoalbuminemia, and they'll have generalized edema. Or their kidneys might not be, their liver, sorry, might not be working well, and because it's your liver that makes albumin and makes protein. So if you think about, you need to think, if you see a child who's got low levels of protein, it's either because they're losing too much, and they can be losing too much from their kidneys with nephrotic syndrome, or from their bowel with a protein losing enteropathy, or they're not making enough protein because their livers failed. So secondly, children with edema can be edematous because they've got fluid overload. They might not have low levels of albumin, they might just be fluid overloaded. So we always should think about anemia or congestive heart failure, or just you've given them too much intravenous fluids. I mean, that can cause severe fluid overload. Or they might have some lymphatic obstruction, like we see sometimes with tuberculous lymph nodes in TB of the abdomen, leads to lymphatic obstruction, and you can get lower limb edema. Or they might have some generalized capillary leak like severe sepsis, and they might have edema because of that. So the main thing is, if you see a child with edema, then go through a process of working out just why this particular child is edematous. I think when you're doing that, you should make like take a history and do an examination, and you want to know if the child is sick or well, if it's focal or generalized edema. Do they have edema in the body cavities, like do they have ascites or pleural effusions or pericardial effusion? Are they pale? They could be anemic, and the anemia could be related to some underlying cause of anemia, or it might be related to iron deficiency, or it might be related to kidney failure, where children have anemia anyway. Or they might be jaundice, suggesting they've got liver failure, leading to low albumin production, leading to hypoproteinemia, and leading to edema. So it's sort of complicated. You have to hold all of these different diagnoses in your mind at once when you're thinking about what the cause of edema is. They might have other signs of protein energy malnutrition, or signs of TB, or signs of lymphatic obstruction like big lymph nodes, or they might have a rash that might be suggestive of some other connective tissue disorder. So when you're thinking about children with edema or possible nephrotic syndrome, then think about all of these different possibilities. The child on the left, of course, has the signs of, oops, I'll just admit someone else. The child on the left, of course, has the signs of protein energy malnutrition with evidence of zinc deficiency and that sort of flaky pate dermatitis, isn't it? And as a cause of this child's edema. And the child on the right, this girl had a severe bilateral lower limb edema, and that was because of TB of the abdomen. So edema is not, all edema is not nephrotic syndrome, and we need to go through a process of excluding other causes, like I've mentioned. This child presented with edema of the lower limbs and abdominal pain, vomiting, and some bloody diarrhea. And she had this rash, you can see. She also had some swelling of the ankles and the knees, and otherwise she seemed normal, but she did have hematuria. Can anyone suggest what's wrong with her?
Yeah, she's got Henoch-Schönlein purpura.
Yes, that's right. Most likely she's got Henoch-Schönlein purpura. Whenever you see a rash like this, a purpuric rash like this, you need to ask yourself, is the child sick or well? If they seem to be reasonably well, and the rash is only on their lower limbs, only on their legs or their buttocks and down their legs, then it's likely to be Henoch-Schönlein purpura. If the rash, this same rash, is on their arms or their body or their chest or their face, on their back, then it's more like, it's not Henoch-Schönlein purpura, and it's more likely to be, what could it be?
Meningococcal.
Good, meningococcal disease, yeah. So it's and a child with meningococcal sepsis will usually be sicker than a child with Henoch-Schönlein purpura. So this is the classic presentation of Henoch-Schönlein purpura, and those children also have a nephritic type of syndrome where they have hematuria. But as I said, that's less than 10% of all cases of nephrotic syndrome, and I really want you to know about this, the common form of nephrotic syndrome, which is minimal change nephrotic syndrome. The way you evaluate a child with nephrotic syndrome is important, and there are some children with nephrotic syndrome that are reasonably well and some children that come in very sick. And so you need to assess the child to see if they've got intravascular volume depletion. This is really important, because some children with, despite being quite edematous, they can be in shock or close to being in shock, because their albumin level can be very low. So all the fluid is no longer in the blood vessels. It's actually outside the vasculature in the tissues. And so you should assess the patient's circulation. And we've talked about this in the last few weeks, that feel the hands and feel the feet, feel if they're warm or cold, feel the, look for the capillary return. I'll just admit some more people. Look for the capillary return. Sorry, there's a couple more people waiting. I'll have to, yeah. So in assessing for the child's circulation to see whether they're intravascularly volume deplete or not, you assess the hands and the feet. Often we look at a child with edema and we think they're not dry, they're not dehydrated, but in fact, they can be intravascularly volume deplete, right? That means in the blood vessels, there's not enough volume, but despite them having too much volume in their total body. And that's just because of the low albumin leads to leakage of fluid out. So you check the hands and feet, their capillary refill time, check the volume of their pulses. Remember I said the radial pulse and the posterior tibial and the dorsalis pedis pulse. That children should have a palpable radial pulse. You should be able to feel it. And see if they've got oliguria or hypotension, or a bit like in dengue, if a patient's got is intravascularly volume deplete, but they're edematous, then often they'll have a blood pressure that's actually quite low, like their pulse pressure will be very narrow. Like it might be 80 on 60, I put 60 on 80, but 80 on 60 with a pulse pressure of say 20 millimeters of mercury. And that would be a very narrow pulse pressure, wouldn't it? A pulse pressure of 20 millimeters of mercury, just like in dengue, how we assess a patient's intravascular volume state by those clinical signs. You should grade the edema, and when you're seeing a child with edema, then you need to know, is it focal or generalized? Is it involving their face and also other areas where you can often see the magnitude of the edema. So often children will have severe scrotal edema or vulval edema in the areas where the soft tissue is the softest, and edema will occur mostly the face, the perineal region. Look for skin breakdown or cellulitis, because many children with severe nephrotic syndrome can have breakdown of the skin or infection. And look to see if they've got pleural effusions or ascites, because if you've got, again, the worst type of nephrotic syndrome edema, then often they'll have bilateral pleural effusions, they may have ascites or pericardial effusion, and that all results from just being severely hypoproteinemic, hypoalbuminemic. As I said, look for infection, because these children, when you've got nephrotic syndrome, it is an immunocompromising condition. And all the children we look after that have got minimal change in nephrotic syndrome are at risk of bacterial infection. And they're at risk of cellulitis because of breakdown of edematous tissue. And they're also at risk of just bacterial peritonitis, which can be spontaneous. It's not that someone drains their peritoneal fluid and they get peritonitis. You can get spontaneous bacterial peritonitis. And partly that's because plasma proteins that leak in the urine is not just albumin. We measure the albumin, but there are other plasma proteins that leak in the urine, and one of those proteins is immunoglobulin. So immunoglobulin is like antibodies. So all the antibodies leak out as well as the albumin, and that can make patients quite severely immunocompromised and at risk of getting like bacterial peritonitis and other bacterial infections. And sometimes these children, because all the serum is leaking out of their blood vessels, then it makes their blood vessels much more viscous and they're prone to thrombosis. And I've seen several children that have had like several cerebral venous thromboses or thromboses in their femoral veins from nephrotic syndrome, because they've been intravascularly volume deplete. All right. So you should check their urine, and most children with true nephrotic syndrome will have heavy proteinuria. It's not just a trace of protein, they'll have heavy proteinuria, 3 or 4 plus protein. You should also check their urine for blood, because if they've got lots of blood there, if it's large, then that suggests it's nephritic rather than nephrotic syndrome, and then you need to manage them a little bit differently. Often in children with nephrotic syndrome, their creatinine will be normal. So unlike the child I showed you at the start where her creatinine went up to 8 or 900, you would not expect that at all in children with nephrotic syndrome. Usually it's normal, but if their creatinine or their urea is high, then it is usually a sign that they've got intravascular volume depletion, and they need some repletion of that intravascular volume by giving them protein or albumin if you can. by correcting their hypoalbuminemia. If their creatinine is very high, then it might be that they've got nephritic syndrome, because nephritic syndrome is more commonly associated with the type of renal failure I described at the start of this talk. Whereas nephrotic syndrome, you shouldn't get bad renal failure. Most children don't have kidney failure. They have edema, but not kidney failure. You check their liver function tests because you want to know what their albumin is. And often children with nephrotic syndrome have very, very low albumins, way less than 25, that might be 12 or 14. And children who've got an albumin of 12 or 14 are going to become very edematous. So unless you can replace their albumin. You should check these patients for anemia, because they're often, if you've got kidney problems, not necessarily kidney failure or some kidney problem, then your kidneys are not producing erythropoietin as much, and so they'll often be anemic, and sometimes they'll be neutropenic or neutrophilic, and that suggests they might have an infection. So remember, I've said in the last few weeks, we've got to make the most of the full blood count, and in children with nephrotic syndrome or kidney disease, you can interpret a lot about their kidneys from the full blood count as well. I hope you all know how to check for proteinuria. And remember, I said if you've got proteinuria, then usually your urine dipstick will be very heavy proteinuria. It'll be fairly dark green, not yellow or tan, but it'll be fairly dark green. So check for proteinuria. Check also for blood. Remember, I said if there's a lot of blood, if it's up this end of the scale, then it's quite likely that patient's got nephrotic syndrome. So they might have heavy proteinuria and heavy hematuria. Then you've got a child with probably that's less likely to have minimal change nephrotic syndrome and more likely to have some other cause of nephrotic syndrome that may or may not respond well to steroids. It's the children that respond best to steroids are those that don't have hematuria, but they have heavy proteinuria. The treatment for nephrotic syndrome is mostly supportive. I'll get onto the specific treatment with steroids in a minute, but it's mostly supportive. The most important part of it is supportive treatment. And so you have to put these patients, as we did the first patient I described, on a no added salt diet. So you don't let them have extra salt. Ideally, you weigh them daily and you check their dipstick of their urine daily or every second day. And you need a strict fluid balance in these patients. So again, you should give them their urine output plus insensible losses, but many children with nephrotic syndrome aren't oliguric. They're mostly passing urine. They're not oliguric like children who've got renal failure. And so you can afford to give them, be a bit more liberal about their fluid intake. You need to maintain their nutrition during the time that they have nephrotic syndrome, because when you're losing lots of proteins, you're losing albumin, you're losing other proteins, antibodies, and coagulation factors. They're all plasma proteins. They can be all lost in nephrotic syndrome. Then those patients get quite malnourished as well. They can look like children who've got kwashiorkor. I tend not to give children with nephrotic syndrome furosemide, as it can make their intravascular volume depletion worse. But if they're in shock, then I would give them albumin first, if you can get it, albumin, and then give them some furosemide to make sure they're passing urine. This is complicated if you don't have albumin, but for most children, for many children with nephrotic syndrome, if their albumin is very low, then it's best if you can give them albumin to get at least their albumin level above 20. If it's very, very much below 20, if it's 10 or 12 or 14, then they will have severe intractable edema, and it's a big problem. I always put these children on penicillin, like oral daily penicillin, just like as if in a child who's got acute rheumatic fever, you put them on penicillin prophylaxis, and I usually use oral daily penicillin because that can prevent them getting pneumococcal peritonitis, which they're at great risk of. And also when you start them on steroids, they're even more immunosuppressed. So using penicillin to prevent infections during the period of time of nephrotic syndrome is important. this is this. I'll send this around, but this is the most useful regime for giving prednisolone to children with a nephrotic syndrome. As I say, I'll send it around. It looks like large doses, but this is milligrams per meter squared. And to follow this this regime, you need to measure the body surface area of the patient. And so we give 60 milligrams per meter squared per day, so a maximum of 60 milligrams. So that means usually a 7-year-old, 7, 8, 9-year-old will be about 1 meter squared. So most adults are about 1.5 meters squared. So many children will be much less than that. So I'll just explain how to calculate meter squared. It's the weight in kilograms times the height in centimeters divided by 3,600, and you take the square root of that. It's not hard to calculate if you've got the formula, and then that can tell you what the body surface area of the patient is. It's a little bit like the BMI. You're using the weight and the height, but it's different to that. And for children who've got a nephrotic syndrome, it's useful if you can do that, do a weight, height, and calculate their body surface area. A bit like we do for chemotherapeutic drugs for children who've got cancer, for example. They're usually based on the body surface area, aren't they? And so it's useful to do that. Alternatively, you can give around about 2 milligrams per kilogram of prednisolone for 4 weeks. That's an alternative way, 2 milligrams per kilogram per day for 4 weeks, and then you slowly reduce it, and you're reducing it over another 4 to 10 weeks, right? It ends up going the total course of therapy over about 10 or 12 weeks for children who've got severe nephrotic syndrome. So it's not just a short course, and we need to be careful about the side effects from steroids in these patients, and we need to be make sure that we slowly wean them off over a longer period of time, and we make sure we get them off steroids because otherwise they run the risk of getting lots of complications from the steroids. I always teach the families, like, children don't stay in hospital for the entire treatment course. That would be wrong. But once their proteinuria is under control, then I teach the families how to test the urine every morning or a couple of times a week to identify early proteinuria. Because if the patient relapses as they're coming off their steroids, then it's best if they present early. If they present too late, when they're all very edematous, then they're less likely to respond to steroids, and you'll need to give it for a longer period of time. So it's nice to teach the families how to check the child's urine and get them to identify when a relapse occurs. You can't always do that, but sometimes we need to see these patients weekly in the clinic to see if they got proteinuria or it's under control. I always think you should, in managing these patients, you should have some red flags, and when to think again. When should you think that this might not be idiopathic nephrotic syndrome? And remember, I said most children with idiopathic nephrotic syndrome respond very well to steroids, and their edema goes away. But if they've got very severe edema, or it's really difficult to control with steroids, then you should think to yourself that maybe it's not just idiopathic nephrotic syndrome, maybe it's something else. If they've got severe, like they've got signs of renal failure with a very high creatinine level, then maybe it's not idiopathic nephrotic syndrome. If they're not in remission after 4 weeks of steroids, then I always worry that they might have something else besides idiopathic nephrotic syndrome. Most children, 80 or 90% of them, will be in remission after 4 weeks of steroid therapy. And so that's usually a threshold time that you should think about, could it be something else? And if they've have lots of relapses within the first few weeks of starting starting therapy, they improve and then you stop it, and within a couple of weeks they relapse, then you should think that there's something else going on. And I always wonder if the patient's getting steroid toxicity, if they're starting to get Cushingoid and you're thinking about using another agent like some methotrexate or something else that might work on nephrotic syndrome, then you should think, is this just idiopathic nephrotic syndrome, or are we dealing with something else? Okay, that's all I want to say about nephrotic syndrome. But what I wanted to do is try to link that with the other common type of acute kidney disease, and that's post-streptococcal glomerulonephritis, right? Or PSGN, post-streptococcal glomerulonephritis. This is probably the most common kidney disease worldwide, and it's a bit less common than what it was 20 years ago or so, but it's still very, very common. And certainly it's one of the most common causes of acute kidney failure in all of Asia. It usually, as you know, it follows 1 to 3 weeks after a throat infection or after a skin infection, usually a bit longer, 3 to 6 weeks. And it like the other inflammatory immunological illness that is caused by group A streptococcus, GAS, group A streptococcus, acute rheumatic fever. It's an inflammatory or immunological condition. And I won't go into the immune aspects of it, but it's just like with acute rheumatic fever, there is it's like an autoimmune response to the group A streptococcus, and the antibodies form antigens that get deposited in the glomerulus of the kidney and then activate complement, which is part of the immune system. And then you get a lot of inflammatory cells like neutrophils gathering in the glomerulus, and that causes inflammation. And so that's the pathology of acute post-streptococcal glomerulonephritis. And these patients end up with hematuria. Remember I said quite heavy hematuria, proteinuria, and it can be so severe that they look like they've got nephrotic syndrome. They mostly have edema because of because often they're oliguric or anuric, and also because of the hyperproteinemia, and they're often hypertensive, so their blood pressure will be high. And sometimes I've seen many children that have seizures, and people have wondered why they've got seizures or poor conscious state, and it's because of their hypertensive encephalopathy. So when we see children who've got nephrotic syndrome, post-streptococcal glomerulonephritis, or they look like they've got glomerulonephritis, then managing their hypertension is a very important a component, because I mean children can die from hypertensive encephalopathy. So trying to keep their blood pressure in the normal range is very important. And as I say, sometimes these children will have acute kidney failure, not just have proteinuria and hematuria, but their kidneys will be failing and their creatinine will be very high. These were 2 children that had different children that had acute post-streptococcal glomerulonephritis, and you can see this child's got severe skin disease from streptococcus infection. Not all streptococcal infections look this bad, but this was a sort of chronic skin disease related to group A streptococcal infection, and he had presented with severe glomerulonephritis. And this is another child that's got a post throat infection, streptococcal throat infection that led to glomerulonephritis. So you can see that both skin disease from group A strep and also throat infection can lead to glomerulonephritis. And I'll just explain, but the types of group A streptococcus that cause rheumatic fever and the types that cause glomerulonephritis are different types. They're somewhat different types. There are the ones that cause glomerulonephritis are called nephrotogenic strains of group A strep. It doesn't make any difference to us, but essentially group A streptococcus can cause both skin disease, throat infection, and that can go on to lead to acute rheumatic fever or kidney failure. Other children with group A streptococcal infections in their hands that can sometimes, it can follow scabies or it can follow any other infection, and that can lead to post-streptococcal glomerulonephritis. This is what a kidney looks like. Actually, this is a microscopic view of the kidney. And remember, I said that the neutrophils invade the glomerulus, and you can see here this is a glomerulus, and it's all jam-packed with neutrophils that causes damage to the glomerulocapillary membrane, and that's why the child leaks protein and leaks red cells. I won't go through the pathology again, but it's an antigen antibody complex that lodges in the glomerulus and attracts neutrophils and other inflammatory cells, and it's called acute diffuse proliferative glomerulonephritis. That's the pathological name, and that's what it looks like under the microscope. When you look at the urine under the microscope, which we can actually do, then there are some telltale signs that this is glomerulonephritis. This is just a normal urine microscopy with a light microscope, right? And what you can see is that these are red cells, and they're what's called glomerular red cells. They're all distorted, and that's because the red cells get pushed through the glomerular basement membrane, and they get distorted and torn as they go through. And this is different if you're looking at hematuria in patients who've got like a kidney infection, a bladder infection, for example. Sometimes children will present with hematuria. Then what you see down the microscope when you're looking at their urine is the red cells look normal. They're not glomerular red cells. They're not distorted or stellate red cells like this. Right, and so you can actually make a distinction. You can ask the laboratory to say, mate, if a child's got hematuria, you ask them to look to see if there's any evidence of glomerular red cells. All right, red cells that have been pushed through the glomerulus, as opposed to lower tract bleeding that doesn't cause these distorted red cells. Often the child with post-strep will have a high creatinine and a high white cell count. They're the other laboratory markers. And if you can do their streptococcal antigens like their ASO titer or their anti-DNase B titer, then you'll find that they're abnormal and high too. This is what sometimes you see, these glomerular red cells, and then sometimes you see this, which is that's called red cell casts. And it just means that this is a cast of the glomerulus with lots of red cells, right? And the red cells are all clumped together. And you don't see red cell casts if you've got lower tract bleeding. If you've got bleeding from the bladder or lower down, you don't see red cell casts. You only see them if you've got nephritis or glomerular bleeding. So the lab can help make that distinction. The differential diagnosis of acute post-streptococcal glomerulonephritis can be, for example, Hinox-Schönlein purpura, or other forms of nephritis. Apart from post-streptococcal glomerulonephritis, hepatitis B is probably one of the most common causes of nephritis around the world. And then sometimes children with endocarditis can get nephritis, and then there's some other conditions that do it. You always should ask a good drug history of patients who've got nephritis, because many drugs can cause glomerulonephritis. And as I said, non-steroidal anti-inflammatory drugs like ibuprofen or indomethacin, they can certainly cause renal failure and a form of nephritis, but lots of antibiotics can cause nephritis too. So if you see children that look like they've got glomerulonephritis and they've, say, been on TB medicines or something like that, you always got to think, might this nephritis be related to the antibiotics this child was on? Because sometimes they can do it. The management of acute post-streptococcal glomerulonephritis, where you treat the streptococcus. So I usually give 7 to 10 days of intravenous penicillin to treat the streptococcal infection if it's bad enough, usually up to 10 days. And you need to treat their hypertension because, as I say, that's probably one of the most the complications of nephritis that's the most troubling and causes the most morbidity, and sometimes serious morbidity like seizures and even coma or cerebral hemorrhage. So you should treat their hypertension and try to get their blood pressure back into the normal range. And I usually start them on some frusemide and use nifedipine to control their blood pressure, and sometimes use captopril if their potassium's okay. But usually I find nifedipine's quite good actually at controlling hypertension in patients who've got acute post-streptococcal glomerulonephritis. Most of these children, they start to improve within 2 weeks. So if their if they're not improving in 2 weeks' time after you start their treatment, then you should think, is there something else going on? And usually by a month, their creatinine is back to the normal range. So remember, unlike nephrotic syndrome, where their creatinine shouldn't go high, in acute post-streptococcal glomerulonephritis, you can monitor their creatinine like I showed you with the first case I presented. And but by 4 weeks, most of these children, the creatinine will be better. And by 6 weeks, mostly their acute post-streptococcal glomerulonephritis is resolved. And the indications for dialysis are really the things that I talked to you about at the start, which we set with that first child I said, and that is if they've got severe acidosis or severe hypokalemia, or they've got intractable, like really hard to control hypertension despite the medicines you're giving, nifedipine or furosemide or captopril, all those things, then you should think about dialysis. Or if they've got uremia to the point that they're becoming unconscious or lethargic, then starting dialysis is a good thing. I never start it so late that the patient won't benefit from it. But also, many children with acute post-streptococcal GN, they get better even if they don't receive dialysis. Okay, as I said, almost all these patients resolve, and some do relapse, just like acute rheumatic fever. Some children with acute post-streptococcal glomerulonephritis, they do relapse, a bit like rheumatic fever. And for some children, their hypertension becomes a big problem, and sometimes they need some albumin support, and occasionally they can get they'll get severe hypertension later on, or renal impairment. So most children with acute post-strep GN, they get better from it, like most children who've got a bout of acute rheumatic fever, but some children get chronic glomerulonephritis related to that. Okay. I was going to talk very briefly about some chronic kidney diseases now, and I'll just talk briefly about this, and I'll send the slides around. The main message is that for most children with chronic kidney disease Can you mute this? Can you mute your device, please? Oh, thanks. Thank you. For many children who've got chronic kidney problems, they are likely to have some congenital underlying abnormality of their renal tract. So they might have obstructed ureters, for example, or they might have bladder outlet obstruction, or they might have hypoplastic kidneys. The most common cause of chronic kidney disease is some congenital renal problem, at least half. And then some children with steroid-resistant nephrotic syndrome, they go on to develop chronic kidney disease. And some children with post-streptococcal glomerulonephritis, they also go on to develop chronic kidney disease, about 10%. And then there's some other unusual causes of chronic kidney disease, which you need to exclude if you're looking after a child who's got kidney disease. This is probably one of the most important and common congenital kidney problems. The reason it's important is because it's surgically fixable, and so if you see a child, usually almost always a boy, in the first few months of life who's oligoanuric, so not passing enough urine, then you should look to see what their urinary stream is like. And usually they've got minimal stream. They just drip urine rather than passing a good stream of urine. And usually when you examine these children, their bladder will be very distended. It'll be up to the umbilicus or even higher. And that's because they've got what's called posterior urethral valves. This is probably the most important congenital renal abnormality, because it's relatively common and also it's surgically correctable. It's an urgent situation, because if you don't correct it, then they end up with hydronephrosis and hydroureters. So important to remember this condition.
Code grade Red 30, ground floor, Main Street reception. Code grade Red 30, ground floor, Main Street reception.
So the renal tract can be obstructed at the bladder outlet. This is like the bladder, and this is the urethral outlet. This is the urethra with a catheter in it. So this is what's called a micturating cystourethrogram, which is just where you pass a catheter into the urethra and then inject some contrast into the bladder and then see how it drains. And you can see that there's an obstruction. There's obstruction here at the bladder outlet and also obstruction in the urethra. So this child's got posterior urethral valves, and this child had a surgical correction and is normal now. Less easy to correct where children have got obstruction to the ureters, so higher up at the ureters, usually at the pelvo-ureteric junction between the renal pelvis and the ureters. And sometimes that can be bilateral or unilateral. And this is a child who's got pelvic-ureteric obstruction. And you can see just on ultrasound, if you do an ultrasound, you can see how distended the kidneys are. This is a kidney, and the renal pelvis is very distended and looks quite cystic. And that's because of obstruction. So sometimes it'll be one kidney affected, and if it's both, then the child will have kidney failure. These a urologist can unobstruct these as well, but often when they're diagnosed, it's not too late, but sometimes they still have some persisting renal problems. So that's where a renal ultrasound is very important if you're investigating children that have got chronic kidney disease. Children with chronic renal disease, as pediatricians, we need to look after the other aspects of them, get the surgeons to see them. They might need surgical correction or drainage, a drainage procedure, but we need to think, what are the complications of chronic renal failure? And the complications are sort of general. So there are complications for growth and nutrition. There are complications particularly for bones, bone strength and bone health. And we often don't think about bone health, but it's very important in children who've got many conditions. So I've talked recently in the last few months about bone health in children with epilepsy, for example, or bone health in children with malnutrition, or bone health in children with tuberculosis. These things we shouldn't forget about bone health. And children who've got chronic kidney disease have particular problems with bone health. And so they often develop quite brittle bones. And that's because the kidneys don't clear phosphate. So phosphate levels increase. Their parathyroid glands produce more parathyroid hormone, and that leads to absorption of calcium and from the bones. So the bones get depleted of calcium. Also, the kidneys don't convert vitamin D3 into its active form, calcitriol, and then the patients get hypocalcemic. So these children, to protect their bones, they need calcium supplements and they need vitamin D, multivitamins, and sometimes they need to be on phosphate binders. So it's simple. Calcium carbonate is what you treat them with, and a low phosphate diet. So they need good nutrition. They need attention to bone health. They need attention to their anemia, because often children with chronic kidney disease have severe anemia because they are not producing erythropoietin. They need their blood pressure controlled, because if they develop severe hypertension, then they can get left ventricular hypertrophy and heart failure, and that can be very severe. So they get severe hypertensive heart failure. So they're the main things. Treat their bone health, their nutrition, anemia, hypertension. They're the things you need to think about. For children with chronic kidney disease, you correct any correctable problems, whether it's surgical or medical. And just realize, I think, that it's not just the kidneys, but kidney failure has effects on many organs, like on growth, on bones, on anemia, the cardiovascular system. We need to avoid drug toxicity. So lots of these children get onto steroids and they get Cushingoid, and that's a big problem. So try to avoid those things. I think that all these children with a chronic kidney disease or any sort of chronic infection, they need a written care plan. And that's our job. We should try to do a written care plan. And they need one doctor that they really trust, who knows their condition really well, that can follow them over a long-term, months or years. And so I always try to teach the families and the child about their chronic kidney problem, their chronic renal problem, and try to encourage them into, doing as many normal things as possible. So going to school and playing with their friends and everything like that. So all these issues are common to children who've got any chronic illness, really. Okay, so today we've talked about acute kidney injury, and we especially talked about one case at the start. Some of you missed it, but a case of a child who had staphylococcal meningitis, who got multifactorial kidney injuries from sepsis and hypovolemia and nephrotoxic drugs like vancomycin and ibuprofen and contrast agent. And so I wanted to convey the need to assess all the different causes of a child's kidney failure. And then we talked about nephrotic syndrome, and we've talked about nephritic syndrome, post-streptococcal glomerulonephritis, and we've talked a bit about chronic kidney disease and congenital abnormalities of the kidneys. So that's all I wanted to say today. I thought it's worth going through kidney failure in detail because we often don't talk about it. And I'm happy to answer any questions that you might have.